Anastasia asked me to talk about the state of pain in America today, which is a really broad subject because there's so many different directions you can go with that remit. So I decided to just give you a broad overview of what's going on. So why talk about pain? Because as Anastasia just mentioned, so many people experience pain. 1 in 5 Americans experience chronic pain. And although the gold standard of care for pain is a multimodal care model, it's not accessible for many people, especially underserved persons, for a variety of reasons. So we'll be getting into that. The cost to our society for pain is over $635 billion in expenses and lost productivity, because if you're in pain, you're not as productive. So historically, pain was known disparately. Pain was always considered a symptom of injuries, surgery, or cancer. So it was something that people thought of in terms of it fits in this box, and then we don't have to talk about it if it's not in this box. There's no room in there for chronic pain, which a lot of conditions have chronic pain. Anyone who experiences cancer, for example, being in remission doesn't mean that you don't have to deal with anything that has to do with cancer. There's this thing called post-cancer chronic pain. Treatment or the lack of treatment was always determined by a physician, not by the person with the lived experience of that pain. There's a social stigma of narcotics, which deters people from disclosing that they have pain or that they're getting treatments. And that's for good reasons, for safety reasons as well. About 20 years ago, I was advocating for a woman in Oakland who, in a church setting, in a support group, she talked about how her pain was finally being relieved, and she was receiving, she had finally gotten a prescription for a very mild pain analgesic. And then she was mugged on her way home. She didn't have anything with her. And then the following week, her apartment was burglarized, and all of her medications were taken, including her diabetes medication and her thyroid medication. And so she had to move just for safety. And it was simply because she had codeine, basically a Tylenol with codeine pain thing. So there's a reason that people don't disclose that they have pain or that they're receiving treatment. Treatment for pain was always siloed. So different physicians wouldn't know what you were being treated for by other physicians, because our healthcare system doesn't integrate all of that information. It's always the onus is on the individual to communicate what's going on with each physician, with each body system, et cetera, which is a heavy burden, especially for somebody who's in pain and having brain fog, which is quite common in that situation. You can't quite think clearly if your pain is off the charts. In the 1990s, communication increased about all of these things, because societally we were talking about cancer pain versus non-cancer pain. There was a lawsuit in California from a family who was suing a physician for undertreating their loved one's pain in an end-of-life situation. So it sort of became confusing. So let's start off with some definitions. So first of all, what is pain? And the International Association for the Study of Pain has this very long definition that basically says pain is what you say it is. So it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it doesn't mean that the pain is always a signal that there's something wrong. It's this combination that's based on your lived experience up to that point where your brain says, wait a minute, I have to set off an alarm and tell you there's pain here, because you are in danger of being injured or you just have been injured, and this is a horrible thing. So for example, with Ehlers-Danlos syndrome, I have dislocated joints, and somebody, even a month ago, I dislocated an elbow, and the new orthopedist that I saw said, well, doesn't it hurt? And I said, well, yeah, kinda, it's uncomfortable. And he goes, well, then you couldn't have dislocated it. I said, no, you don't understand. This isn't the first time it dislocated. This is like, we're in double digits here. And I do remember the first time, and it hurt like a son of a gun, and I couldn't talk. But then once I understood the mechanics of what was happening and what the recovery plan was going to be, it became less scary. And so the perceived pain went down. So pain may persist despite successful management and addressing whatever the underlying cause is. What is chronic pain? Chronic pain is pain that persists or recurs for longer than 3 months. So Anastasia has had this hip pain that she's been dealing with for a couple of years now. Finally, she's had the surgery with the replacement. And so her brain is a little confused. Sorry to use you as an example. Her brain's a little confused right now because it's dealing with the chronic pain, the issue of, okay, I'm conditioned to pay attention to this joint. There's chronic pain that's been going on for a very long period of time. And there's also the recent surgery or injury or insults to the body that all of that brought. So there's a whole bunch of other new sensations. So your brain, don't feel bad, Anastasia, your brain is a little confused about what pain is more important to be addressing and paying attention to. So chronic pain is a frequent condition affecting an estimated 20% of people worldwide. And it's got multiple factors that contribute to it. As I alluded to earlier, there's the biological aspects of it, there's the psychological aspects, and there's the social factors. The stigma, the isolation that occurs. If you're in pain, you aren't able to go out and participate in some of the things that you used to do or that you would like to do. So what are we talking about? Now, the ways that we address pain or the ways that we talk about pain in this country gets even more confusing because we've got the media telling us one thing, we've got advocates telling us another, we've got politicians telling us something else, we've got scientists telling us something, and doctors telling us something. And it's all sort of smeared together with all different colorizations that might make it negative or might make it more positive. So let's continue with figuring out some definitions here. Opioid is a word that we use to talk about controlled substances. So that means we know where they're manufactured, how they're distributed, when they're prescribed, who gets them, how much they're getting, et cetera. And that's in our prescription medicine or in our over-the-counter, we know who manufactures them and then who sells them, et cetera. And that's controlled substances used to treat moderate to severe pain that targets opioid receptors in the brain. Narcotics originally referred to any substance that dulled the senses and relieved pain. And narcotic is a word that for hundreds of years has been used. In Sherlock Holmes stories, you hear about narcotics, for example. In old-time radio programs, you often hear about narcotics. And those are, in the colloquial sense, it sort of refers to the illegal opioid-based substances. Now, if we're talking about people with substance use disorder, it used to be we talk about people who had addiction, they were addicted, or they're crackheads or whatever, so, or alcoholic. Now we talk about substance use disorders or SUDs. And these are chronic diseases characterized by an individual continuing to take a substance despite its negative effects. There's a pattern of use of those substances leading to impairments in health, social function, and control. And it changes their behavior. Why is this of concern? So the words addiction, tolerance, and physical dependence are often used interchangeably when it comes to drug or alcohol use, but they don't mean the same thing. These things may be true for prescriptions, over-the-counter medications, alcohol, caffeine, cigarettes, etc., street drugs, whatever. So understanding what we're talking about, tolerance is not a bad thing. Tolerance develops over time with the use of a substance. It becomes less effective, so it may require a higher dose to get the same results. And how much do you need to feel the effects? So antidepressants, for example, people develop a tolerance to, and so you might have an increased dosage amount over a period of time. Sleep medications fall into that category, and diabetes medications and thyroid medications. All of those, you have blood work to monitor them or other tests to monitor them to determine the effectiveness, to make sure that we can titrate that dosage up and down to have the ideal effect in there. Dependence, contrary to what some anti-addiction or anti-overdose efforts might have you think, dependence simply means that physically your body starts to rely on that substance. And if you were to suddenly stop using it, you would likely experience some pretty serious symptoms, some withdrawal symptoms, for example. And that can be true for vitamin supplements, that can be true for pain medications, analgesics, it can be true for diabetes medications. If you suddenly stop them, you're subject to some really serious side effects in there. Addiction is the continued use of a substance, even if it has no medical benefit, no matter what, and despite any consequences. So there's a distinct change in behavior, there's a craving, there's a willing to do anything to satisfy that craving, which has an adverse impact on societal behavior for those individuals. All right, so is there really an opioid crisis in this country? It depends on who you ask. And if you ask them, if there is an opioid crisis, where does it come from? You get all kinds of different responses and sources. So there's this sort of word soup in this graphic. People who have lost a loved one to overdose of any kind often blame those who are involved, physicians or patients or pharmacists, etc., for the loss of their loved one. So they are driven to restrict access for everybody else. They don't want anybody else to have to go through this, and they feel like the root of the problem is all opioid substances that are out there need to be removed from society. Well, that doesn't do anything for the people that are living with chronic pain, for whom these things have worked for a very long time. And so it's unfair, and we have a lot of unintended consequences. So the more we restrict opioid medications and access to them within the known pipeline, the increase actually is what we found in the last 10 years of overdose deaths, because that drives more people out to illicit drugs. So fentanyl, for example, you hear a lot about a fentanyl crisis, and it isn't the fentanyl itself, it's the other things that are being put into the fentanyl to traffic and sell it illicitly, so illegally, and on the streets. It's the other stuff that's in there, and the higher doses and the unregulated doses of fentanyl, plus whatever other ingredients are in there to enhance the high or make it more appealing in some way, that leads to an increase in overdose deaths. There's assumptions made that overdose deaths are directly tied to opioids, and that isn't true. For the CDC, if you were to break down all of the overdose death statistics that they get, you find that a single opioid is not going to be what leads to the overdose. It's what's called polypharmacy. So there's more than one drug in there and more than one interaction. Also, the things like Tylenol, Benadryl, potassium supplements, those also lead to overdose deaths. And they're not as much talked about because there's no funding opportunity for law enforcement or for the DEA. So at local, federal, and state levels, it plays a part in how they justify increasing funding for law enforcement if they're fighting this so-called drug war, et cetera, and they can point to statistics. There's a lack of mental health treatment in this country, and that's been widely acknowledged, and it seems to be the reason why we have all of these societal ills. Well, in our country, our physical health and our mental health systems have been separated. Suicidality is an issue, and it happens on both sides. There's people who are not getting mental health treatment, who are choosing illicit drugs or substances, alcohol, et cetera, as a way to cope with their mental health issues. There are also people who have chronic pain who are not getting treated that are choosing suicide. So suicide isn't a one side of the issue or the other sort of thing to consider. So there's also coverage in theory about how to manage pain, but there's discord between what the science says and what's available. So the Centers for Medicare and Medicaid, the Center for Medicare and Medicaid System, CMS, is the basic basis for all public and private coverage of health services. Whatever CMS says is going to be covered, eventually private insurance companies will then cover it in some way. So the best example I can give you is that acupuncture has been embraced and researched specifically for low back pain and shown to be effective. There's science backing it up, and CMS says, yes, we'll cover it, but Medicare providers list doesn't include acupuncturists, licensed acupuncturists. Part of the problem is different states have different licensing requirements for acupuncturists. Part of the issue is that acupuncturists have different training requirements in different countries even. So there's a disconnect there. CMS says we'll cover it, but good luck getting it covered because there's nobody on the list in there. Telemedicine is a way to overcome where people live to get their healthcare treatment, all types of healthcare treatment. And its telemedicine access during COVID-19 was shown to be very, very effective for mental health care, for physical health care, for sustaining prescriptions, et cetera. And at the same time, we had CDC guidance was becoming legislated in states as requirements, which is again a discord. Showing that we needed, according to those CDC guidelines, we needed more oversight from doctors in refilling prescriptions, and requiring the individual with a prescription for an opioid analgesic to be coming in and doing a urine test, usually at their own expense, and to be physically seen in person, answer some questions before they can have that prescription refilled. So let's talk about a couple of individuals. So first of all is Finley. Finley had an injury of the spine at 23 years old. The diagnosis, because Finley was in the medical system and they finally determined that there was an underlying bone degeneration disorder. So physical therapy 8 times a year, it was limited, even though Finley would have benefited from more physical therapy to build up. You know, physical therapy, you start with saying, oh, it's the hip that's hurt, so we'll work on the hip. But then we also need to work on the alignment of lower and higher than the hip. So 8 times a year is not enough. In Finley's case, there were 8 surgeries, and they were treated with over-the-counter and prescription analgesics. They needed assistance for daily functioning. They requested mental health care and it was denied because it was determined that this was a physical problem. Finley went through a divorce after the 7th surgery and then lost custody of access to their children because of stigma. The spouse fought in court and said, but Finley has this prescription for opioid analgesics, and that's too dangerous to have around these children. So therefore, my children should never be with Finley unsupervised, which was ridiculous because Finley had the medications in a lockbox up on a high cabinet, and there was a nurse's aide who came in daily to give them their medications for the day. So it really was a false argument in there. Because Finley lived too far away from major healthcare systems and access. So basically in a rural setting, it was difficult to find healthcare providers that would treat them. The local pharmacy refused to fill the prescriptions because they were for opioids. And so even though they started to, after a couple of years, the pharmacy changed pharmacists, and the new pharmacist was so anti-opioid, they said, no, you've been taking them too long. I will no longer fill this prescription, which meant that Finley had to go in person to a pharmacy several hours away to get it refilled every month, etc. So part of the divorce settlement was a change in healthcare coverage. And unfortunately, Finley passed away 4 months after that insurance change. And what happened was that Finley was required to go into a new pain management clinic under the new insurance after close to 10 years of being treated with high-dose opioid medications. Remember, tolerance was up and there were withdrawal symptoms, et cetera. The new pain management system went too fast in titrating down. They wanted Finley to stop cold turkey, which would have been detrimental. And they compromised by reducing the dosage and changing the formulations, et cetera. Opioids have a negative impact on your lungs, your breathing ability. And Finley got a cold and the flu and then a sinus infection. And they went to the emergency room for that sinus infection. They were turned away and labeled as drug seeking, even though Finley's issue was breathing and wanted to breathe. And they kept saying, well, just stop taking the opioids and won't be a problem. And unfortunately, Finley died of pneumonia and an untreated respiratory infection as a result of that. So those are the types of dire consequences we're talking about when we're restricting opioid access just across the board. And Casey has a different story. So Casey also experienced a workplace injury. The claim was denied. They were fortunate enough to have high level of education. They were able to change their career, get different health insurance. They lived in a metropolitan area and had access to university healthcare centers with more up-to-date research and more clinical trials, et cetera. After 25 years with the same doctor, prescribed at stable doses of the same medications, things changed because of the CDC guidelines, which were being misapplied elsewhere. But being in this metropolitan area, Casey's able to overcome some of these obstacles. They had access to mental health care, which means that they had a variety of integrative options available to them: visualization, counseling, meditation, CBT, all kinds of options, biofeedback, et cetera. And because they were able to change career and they had a very supportive family and spouse, they could pay out of pocket for massage, acupuncture, and aquatic therapy. The insurance company denied prescription coverage, despite having 25 years with this stable dose, and they required reassignment to a new doctor. This new insurance company also required urine drug testing, which Casey had to pay for every single month. So that's a couple $100. Insurance denied physical therapy, just as in Finley's case, for a pre-existing chronic condition, because the chronic condition existed before this insurance company came to provide coverage. So the family continues to support and pay for physical therapies, prescriptions, and out-of-network visits to the previous doctor in order to maintain this. But this is not a sustainable model. They're going to go broke doing this. So what's the gold standard for treatment? As I said early on, it's biopsychosocial pain care. And it's not accessible, even for people like Casey, who are living in the right place. And so how should pain be treated? We need to look not just at pills and procedures. We need to look at medication combined with restorative therapies, combined with interventional procedures, behavioral health approaches. It's a complementary and integrative health approach with risk assessment that addresses stigma, location, etc. Another graphic to consider is consider how you think about it is there's disciplinary care where your apples are in one section, your oranges are in another, your bananas are in another, but they're not talking to one another. They're not mixing together. Multidisciplinary care means that they're all in the same bucket, but they might be segregated within that bucket. Interdisciplinary means that they're all jumbled together and they are communicating with one another. Transdisciplinary means it's all, we put them in a blender, we made a smoothie of it, and it all works out. And so there's this wonderful graphic here, and Anastasia can share a link in the chat for everyone so you can access this and get more information about it. But it shows you what your options are in the outer ring, and these are just examples. There's more than what will fit in here, and how to think in terms of, if I am at the center of this and I am experiencing pain, what do I need to be asking for? What do I need to be looking for in that way? The challenges are that there's no equity in this. Even for those of us who are privileged enough to have the right insurance and live in the right place, we have to know what to ask for. We have to be ready to address misperceptions and stigmas of the people that are in our own homes or the people that we're interacting with at work or whatever. We need to make sure that there is education of all of those people and of healthcare providers. And are the right healthcare providers available to us? Are there enough of them? There are not enough rheumatologists in this country to address all the people that need a rheumatologist. So how do we move forward? Well, we need to advocate for appropriate care for ourselves and our families. We need to find out what is covered by the insurance that we have available to us. So that would be the first assignment I would give all of you, is to look and see what is covered by insurance for acute pain, for chronic pain, and for ongoing healthcare, other chronic health issues in there. Embrace the emerging digital interventions. You know, there are so many, there's so much data that can be collected that can give you insight into what's going on with your body. So if you have an Apple Watch, for example, get to know all of those little health applications in there and figure out, well, okay, I had a really tough day today. My hip was hurting a lot more. Well, how many steps did I do? And what was my heart rate like? Were there any peaks or something that might have been a result of what I'd done that I can, and then apply to change my behavior to prevent this happening, or pace myself to go more slowly. You need to affect legislative and regulatory change. Don't just take it for granted that because somebody stands up and says, well, my daughter died because she went to a party and she dipped into a bowl of pills and took an opioid or a fentanyl or whatever it was. That is what we call prescription diversion. And they died. And so you can't say, therefore, we shouldn't have any of those pills out there at all. These things all need to be in balance. Encourage research, participate in research. There's opportunities at UCSF. There's opportunities at UC Davis here in California. that are looking at pain, that are looking at mental health care, et cetera. It all feeds into that. Always volunteer to be a research subject in these, in everything that's out there, because there is a pain component to just about every healthcare research project in there. Try everything yourself. Go back to that graphic, that wheel, and use that as your shopping list of things you want to try. Search online, because there are a lot of options that are free and available to you no matter where you are in the world, that can help with meditation, mindfulness moments, visualization, calming exercises, sleep management, hydration management, nutrition management, all of those things. There's a lot of guidance out there available for free. Advocate for access to multimodal care. More importantly, push from your side for your insurance company to cover the things that the research is saying will work. And they, refer back to that acupuncture example. NIH produced the research that says that acupuncture works for low back pain. CMS said, yes, we'll cover it, but insurance companies won't cover it because of the licensing disparity. So now you're looking at all the different places where you can do that. So those are your tasks to consider and things to move forward. And now I am willing to take questions.
Thank you, Maggie. That was awesome. Let's open it up for questions, but I'm actually going to start with one myself, and then anyone else, if you can ideally use the little the hand that you can click on reactions in the lower right side of your screen and raise your hand. That makes it easier to find everybody. But if not, you can always speak up. So Carl, if are you good with still keeping up with the Q&A? Okay, perfect. So my question, I would say thank you. This has been so helpful and exactly what I was looking for. I would like to know a little bit about your journey and what some of your go-to resources are that you have used over the years and currently that have supported you in your pain management.
Well, I'm going to turn that around a little. So as a patient advocate, people come to me and they say, I'm having so much trouble in managing my pain and I don't feel like I'm doing anything. So then I will ask them questions about, well, what was the first thing you did when you woke up this morning? Did you get out of bed right away? What did you do? And so if the answer is yes, I just got out of bed right away and I felt unsteady, I'd say, well, next time, take a moment, do a body scan, relax, align yourself before you go and stand up. Then the next thing you do is you're going to drink some water, because hydration contributes to the function of your nerves, the function of your brain, et cetera. So you've been asleep or in bed overnight, you're dehydrated, whether you realize that or not, and that impact increases with it as we age. So it's very important to take your time getting out of bed in the morning. Make that part of your practice, part of your body management. Think about eating. When do you need to eat? What do you need to eat? And how often do you need to eat during the day? So there's some really basic things that I do to manage my pain in that way. I start my day with meditation before I get out of bed. Sometimes I fall back asleep. Yesterday, I just fell back asleep for an hour after 20 minutes of meditation, which is okay. Obviously, my body needed it. I do manage my hydration and my nutrition. I eat every couple of hours instead of 3 large meals during the day. Sleep management is very important. Going to bed at the same time every day, setting a goal to get up at the same time every day, making sure that you give yourself enough time in bed to get enough sleep for what you need. And that's very subjective. All the recommendations out there are anywhere between 6.5 to 9 hours, depending on your age or whatever. So figure out what's right for you. Exercise, movement is lubrication for the joints. So if you have a problem with stiff joints, walking, moving, if you aren't able to walk, even just lying down and doing bicycle feet, or rocking in a chair, because you are activating your legs, you're pumping the blood, etc. You're moving back and forth. That helps with your internal organs as well in that way. I also have found benefit from regular massage, regular acupuncture treatments. I do have pain medications for when it gets out of control, or it's called breakthrough pain. So it's more than what I'm usually used to in that way. And so many more things, but look at that wheel graphic that Anastasia put the link for in the chat.
All right. Do we have any more questions, Michael Milstein? You're muted, Michael.
Okay, now that cannabis is legal in most states, how effective has it been in your experience?
It depends on the individual, and it depends on the type of pain, and it depends on the delivery of the cannabinoids. So obviously, if somebody has lung pain or respiratory issues, smoking it is not going to be the ideal route. And for me personally, it doesn't really help. There are some topical creams that I've found that have been helpful for acute situations. There are other people that I know with Ehlers-Danlos syndrome for whom it's like a vaporizer. So she has a heating thing that has a cannabinoid oil that she generates herself, she makes herself. And then when she does that in the evening, she's able to relax and she gets a better quality of sleep, which then leads to better pain control. Because if we have a lack of sleep, it actually has been proven scientifically to cause the symptoms of fibromyalgia, which is chronic pain, chronic fatigue, etc. So sleep is very important. Most people that I know that use any type of cannabinoid, whether it's a pill, a capsule, smoking, edibles, whatever, it's usually the biggest benefit they have is for helping to manage their sleep, not necessarily manage their pain, and it provides distraction. Distraction is a valid way for pain management. It makes your brain pay attention to something else. And whether your distraction is getting high and watching Cheech and Chong or comedy, or your distraction is playing solitaire online or best fiends, whatever it might be, it's all good.
Well, watching Cheech and Chong always removes pain, I think.
That's right. That's right.
That's
Laughter
always a good
is
idea.
the best medicine, right? Laughter is the best medicine.
Very good. Anybody else with a question?
Bill Buchanan and Susan Roan.
Okay.
Good morning. Good morning, Maggie. Thanks for spending some time with us this morning on kind of a commonality, in the human species. Those of us who have been through Marine boot camp, like Don Persky and Tim Durkin, will recognize the phrase that pain is weakness leaving the body. Now, you usually hear that when a Marine drill instructor is hanging over you trying to finish that 45th push-up. Pain is weakness leaving the body. Never mind that. But as you were talking, and we got into discussing acupuncture, I remembered that my wife, Claire, who's, both of us have been very athletic all through our lives, some years ago had pain. I think it was in the sciatic nerve or something like that. I said, why don't you go see Golden Gate Breakfast member Johnson Yu, who had a practice, still have a practice in San Francisco. Try some acupuncture. She said, I don't know. It's not approved everywhere. I said, try it. It worked. Now, lately, she's developed something called TMJ. It's a jaw pain syndrome. Comes, maybe once a quarter. I said, look, try it again. And so she went to a local Marin acupuncture, and lo and behold, it worked. So my question is, why isn't acupuncture more widely accepted by entities like Medicare. I mean, our insurance covers it with a usual deductible, of course. I'm surprised that such, at least in our personal experience, has been that acupuncture has worked in these pain syndrome situations. Why isn't it more widely accepted?
I agree with you. That's one of the great mysteries that I've been trying to solve, and one of the things I've been trying to advocate for in recent years. Because for me, acupuncture is like magic. And for those who haven't had an acupuncture experience, you go and you have the undivided attention of a practitioner who really listens to you. So there's the emotional support in there. You are in a setting where they sort of force you to relax, disconnect, take time out, etc. So there's a physical and emotional benefit just from being there, in addition to the magic of the needles, which somehow interrupts whatever the science is behind it. So for me, it's been magical, and I want other people to be able to experience that with a really good practitioner. And there's different types of acupuncture as well. So they might use your full body, it might be just your extremities, it might be just your head. So finding the right practitioner and the right type of acupuncture. So there's different regulations in different states. In some states, acupuncturists are not regulated, they aren't licensed. And CMS requires that it be a licensed acupuncturist, but they don't define what a licensed acupuncturist is. And so until we get that clarification from CMS, other insurance companies are reluctant to embrace that as something to be covered in that way. So there are some healthcare systems that have acupuncturists on staff, and it's usually a physician, an MD or a specialist physician, who also has become a licensed acupuncturist in their state, and that's the workaround to get it covered. Does that answer your question? We need to tell more people about it and advocate for clarification at the federal level and at the state level.
Very clear. Thank you, Maggie.
Okay. Before we move on to Susan, I just want to say, normally we do not record Q&A at the end, but personally, I'm feeling that a lot of information is coming out during this Q&A. So if it's all right with everybody, we'll continue recording, but if anyone has any problem, send me a message, I'll turn it off. Now, Susan.
I guess I better not say any 4-letter words.
That's right, damn it.
Oh, wait, but my favorite is sail, not the kind with water, the other kind. What you're talking about just resonated in so many ways, because I know people who've taken pain management classes, and it really talked about so many, like the integrated the diet, the sleep, etc. But one of my friends, and I'm sure you've heard of it, has post-polio syndrome. So does my brother. And she cannot get pain medicine because the doctors in Massachusetts are scared to death to prescribe, because there's been such an amount of investigation. Now, I don't know if you all know it. I think it's Walgreens fulfilled, 80,000 opioid prescriptions, and now he has to pay the city millions and millions and millions of dollars. So that's an unbalance. On one hand, someone who needs it can't get it. Walgreens is filling them for just everyone. So what does someone do who really has a situation that requires opioid when doctors are backing away, but Walgreens is filling them? Some of them might not have been even real. So is there a solution?
There is, and there isn't. And it requires advocating, tapping into the right resources locally. And there is I'm trying to think of what it's called, the Massachusetts State Pain Advocacy Alliance, or whatever.
Thank you.
there is, I will find that out for you, Susan, and I will get that to you. But there is a group of patients and advocates in Massachusetts itself. Massachusetts is actually one of the easiest states to get appropriate pain care in, because of the advocacy work of, if you want to Google Cindy Steinberg, she lives in Massachusetts. Cindy is the first name Steinberg, Steinberg.
Yeah.
And she's with the US Pain Foundation, etc. But she started the group of patients and advocates in Massachusetts. And there's actually laws that have been changed in Massachusetts to increase access for people like what you're talking about with chronic conditions such as post-polio syndrome.
Yeah, thank you for that, because my friend's daughter had to say to the doctor, my mother's 82 in pain, and if she becomes addicted, so be it, but get her out of pain. So
Exactly.
Thank you for that. I will call my friend immediately. Thank you.
Yeah, and that's a common occurrence, especially with the elderly, either because of stigma or they're paying attention to the headlines in the news, and they say, the doctor or the family member says, oh, I don't want my 85-year-old father or mother or uncle to have that because I don't want them to be addicted. It's like, well, I don't want them to suffer for the rest of their life. I don't want them to end their life prematurely simply because they're in pain and they can't get it addressed in that way. So it's important to balance that news coverage. So even though we see the headlines about Walgreens and the penalties they're having to pay in San Francisco, bear in mind that is headlines for anti-opioid advocates. That is the headlines for example, I testified in an FDA hearing about time release opioids and the effectiveness of those in a chronic healthcare condition. And after my testimony, there was a break and I went into the restroom and a woman followed me. And she followed me into the handicap stall and her finger was this close to my face, pointing at me and telling me that I was the reason that her daughter had died. Because people like me kept insisting that we needed access to these medications that kill so many people. And so when you see those headlines, I want you to think of that woman and her grief and give them some grace to understand where they're coming from. But also think about your own situation, or in the case of Susan's friend, of they need, for a legitimate reason, to have their pain managed. They deserve the respect and the compassion to have their pain managed just as much as these other people need to have their grief addressed. And there is some overlap in a few groups, but usually it's very polarized. So when we see those headlines, it's because it's safer and easier for the person who's anti-opioid to come forward. Remember the patient that I was advocating for from Oakland who had to move out of Oakland and change to an unlisted phone number, unlisted address, a different name on the post box, etc. So we have both of those situations going on, and we need to be the voice in the middle of sanity that says, yes, both populations deserve to be addressed. Both populations deserve compassion, grace, understanding, and support.
Betty?
First of all, thank you for being here, Maggie, and an excellent presentation and bringing this amazingly important topic to everybody's awareness. I actually, this is near and dear to my heart, having been a family nurse practitioner, dealing with chronic pain, acute pain, with patients, trying to determine who is telling the truth and who isn't, but pain is pain, whether it's perceptive, whether it's real or it's real to that person, or are they just being manipulative and crazy? I mean, it was just so much over the years. And then having dealt with it with myself, both acute and chronic pain, arthritis, on and on, we all are touched in so many different ways. And years ago, I felt that before I became a nurse practitioner, I thought every patient needs an advocate. And I love the word advocate. And then I became a nurse practitioner, and it just kind of all fits in. But we all need advocates, even when you go to the doctor and the doctor tells you something, or your partner or spouse or whatever, they walk out of there and they remember 20% of it. So, I mean, everybody needs somebody. And I guess I don't really have a question, but I think what you're doing is phenomenal, number one. Number two, I was involved in some of these fundraisers for pain management years ago, and with my physical therapist friend and so forth. And I had heard at that time, 1 in 4 people have chronic pain in our country. And I saw your statistic was 1 in 5, but we all are dealing with it in some way. But my question, so I could go on and on, so many examples, but the question is, how do we get more people involved and aware in what you're doing? We need more Maggies. And how are you going to schools, high schools, getting into a career? This is so important.
Well, yeah, well, pain management, I don't know how far I want to go. You've just uncapped something here. So part of the problem is that the patient support organizations around pain have been driven out. And that's as a consequence of the efforts of the anti-opioid lobby, if we call them that, and a few lawmakers in particular, such as Chuck Grassley, who led this effort starting about 20 years ago. And so in George Bush's, sorry to make this political, in the first term of George Bush, within the first few months, there was a funding crisis, a budget crisis. There's always a budget crisis, and funding for DEA was going to be cut. And so prior to that, prescription medications were overseen by CDC and FDA and the ATF, oddly enough. So they decided to reassign prescription medications from ATF to DEA, because prior to that, DEA had been just illicit drugs and street drugs. But they said, but wait, if we put prescription drugs over here, we know who manufactures them. We know who distributes them. We know how they're transported. We know how they're prescribed. We know who gets them. We know who's taking them. And we can follow up in that way and minimize diversion. So it was a tactic to bolster the funding or fight against any reduction of funding of DEA. So then that became the low-hanging fruit that law enforcement could say, we're doing our job. Look, we have statistics to show it, because there were no statistics that they could fall back on for illicit drugs. They could only say, we caught this much, we found this much, we prevented this much. And at that time, there were easily 36 patient support organizations. The American Pain Foundation, a lot of professional medical associations had patient support arms that were associated with them. And they were funded by monies that came from pharmaceutical companies. The money that came from pharmaceutical companies was dictated by the FDA as part of their patient education. And part of the regulation was that they could not dictate how that money was spent or the messaging that was in there. However, Chuck Grassley decided that if the pharmaceutical companies are giving money to these patient support organizations, they have an impact on what the message is. Therefore, they must be brainwashing everyone to say that they need and want opioids, and we need to cut off that funding. As a result, we lost 24 of those patient support organizations because they no longer had funding. And some of those organizations were subject to investigation by the Senate, by law enforcement, etc. And that's part of why they went away. So that's why there's so few of us out here now and public but there are still some organizations. There's US Pain Foundation, there's the Pain Community, which I'm on the board of, and Anastasia did put the link in there for that. If you go to my LinkedIn profile, you'll see some of the organizations that I've been a part of in the past. And then there is the pain managementalliance.org is the website. It's the same website where the Anastasia shared the link for the wheel graphic in there. And that brings together all the stakeholders, because we realized that it isn't just the patients who need to speak up, it's the caregivers, it's the nurse practitioners, it's the physicians, it's the acupuncturists, it's the massage therapists, it's the yoga therapists, it's everybody needs to be working together with the same message to increase access and talk about solving the problem holistically instead of piece by piece in that way. So supporting those types of organizations. Unfortunately, the Alliance to Advance Comprehensive Integrated Pain Management, painmanagementalliance.org, our funding comes to an end at the end of this month. And we would like to continue that organization. So if you know anybody who's got a couple $100,000 laying around that wants to support this effort, certainly let me know. Because we do want to do that. Now, the people that are behind that, including myself, we are so committed that we are actually scheduling a meeting and a meeting for December to continue the work and continue the effort on our own time. We're just not able to support it with the infrastructure that it really deserves to go forward. But we are searching for money in that way.
Thank you. I hope you succeed.
Thanks.
I have a quick question for you, Maggie. I remember back in the 80s or so that there was a major thrust in the medical community towards pain management. It was a big deal.
Yep.
And then everybody started pulling back and walking that back. Did that have to do with lawsuits, malpractice suits? Why did the profession start pulling back?
Well, if you go back even further, you'll find that it waxes and wanes. And so so you can go back 200 years and you can see, oh, laudanum, you read about it in stories or you hear about it in TV shows, et cetera. And so then you can actually track it through the waxing and waning periods through fiction and through history of where it's more available and then it becomes less available and it becomes more available and less available. This continues to happen throughout history, and it has to do with a variety of things. And again, it's that woman who lost her daughter versus me with a chronic healthcare condition, and how is it supervised? And everybody has a different idea of how it should be regulated or how it should be available. And when there's money involved, which is more often the case now, there's money comes into play with how do we treat the overdose issues? How do we treat healthcare? Our healthcare expenses are our biggest outlay of expenses, public expenses in this country. And so how do we control that cost? Well, we control the cost by providing comprehensive integrated pain management, which includes everything, as well as mental health support needs to be widely available to everybody.